Dr. Arun Kochar, who is a senior interventional cardiologist at Fortis Hospital, Mohali. He would be talking on the modern drug treatment of heart failure. On behalf of Docplexus and our entire audience, we would like to welcome you, Dr. Kochar.
Thank you. I'll be talking something which is important as far as drug treatment of heart failure is concerned. In last 20 years, a lot has happened as far as heart failure treatment is concerned to a common physician or to a cardiologist. And much of that has come in last 4 or 5 years when two new drug therapies have become a common platform where uh, heart failure management has taken a different turn. And now we can hope that heart failure patients can afford to live a longer life, a more fruitful life with less admissions, less morbidity, and less mortality. So, without further delay, we'll be starting on this series of masterclass with the modern drug treatment for heart failure. So, heart failure is increasingly becoming common as far as incidence and prevalence is concerned. In a country like India, where already rheumatic heart disease is very common, the added burden of acquired lifestyle diseases such as coronary artery disease or CKD or diabetes have increased the proportion of patients of heart failure, and we are able to see more and more patients coming up with heart failure in our OPDs and IPDs, and the incidence is only going to increase in coming years because India is the diabetic capital of the world. India has the maximum number of myocardial infarctions that happen globally. So, with both these conditions, where acute management has improved over the past years, and the longevity of the population that has improved over many years, many decades, we can hope to see that more patients they live longer, and of course these patients will come back to us as heart failure patients. So, heart failure is something which is common, and as one ages, the prevalence of heart failure increases. It is assumed that 1 in 5 people who are adults, they'll go on to develop heart failure in their lives. Currently estimated there are 64 million people who are living with heart failure. That is almost 1 to 2% of the adult population. And the mortality and morbidity is extremely high of patients who are suffering from heart failure. If you look at different cancers, then probably they have better prognosis compared to heart failure. Many a times we believe that cancer is more of a threat to human life than heart failure. And even clinicians believe that our patient is stable on heart failure, so we do not have to worry. But it has been seen, this is a Scottish trial of almost 60,000 patients, where the longevity was compared with heart failure patients of different cancers. And it was seen that almost 50% of the patients, they succumb to their illness within 5 years. The US data also tally with this finding. And it is seen that most of the heart failure patients have multiple comorbidities. Only 3% of the heart failure patients, they do not have any comorbidity. Whereas cancer, only 1/3 of the patients are having comorbidities. Most of them have single disease of the cancer which they are suffering from. So that added comorbidities such as diabetes, such as CKD or coronary artery disease or rheumatic heart disease or sleep apnea, they contribute to the enhanced mortality which is visible in heart failure patients. As I said, many clinicians believe that their patient is stable, it is NYHA class 2 or 3, is doing well. So they believe that heart failure is a stable condition. Now, what we have discussed, it is apparent that there is no stable heart failure. We never talk of stable cancer of the colon or stable cancer of the lung or stable cancer of the breast. But still, we go on and believe that our patient of heart failure is stable. It's an unstable disease right from the beginning. And unless corrective measures are not taken, unless enhanced surveillance is not placed, patients are at increased risk of sudden cardiac death or pump failure. So there is a added unawareness about the magnitude of the problem. And that, of course, is visible with our policy makers also. In this union budget, of course, there is enhancement of budget allocation on healthcare. But before that, also, India had a dismal allocation of budget allocations for healthcare. And most of the times, our GDP contributes to 1 or 2% of the healthcare expenditure. Nonetheless, heart failure, as we understand, is a very unstable disease right from the beginning, and more resources and enhanced surveillance need to be placed both by the government as well as the public, which also includes doctors as well as patients. So everybody should consider heart failure as a malignant disorder right from the beginning. Now, what is the situation in India? As I said in the beginning, that rheumatic heart disease is an important healthcare problem in India, especially in rural settings. That disease also contributes to the increasing prevalence of heart failure situation in India, and compounded by the fact that we have now lifestyle illnesses coming up. So it is believed that 1% of the adult population of India is suffering from heart failure. That almost is equal to 10 to 15 million patients living with heart failure in India. In India, it has a post-admission mortality of 20 to 30%. That is at one month. So any patient who gets admitted for acute heart failure, then within the admission first month, there is expected mortality of 20 to 30%. And yearly mortality is almost 50% of acute heart failure patients who get admitted for acute decompensated heart failure. India has a very dismal adherence to medication, 25 to 50%, and most of the time, the guideline directed medical therapy doses are not reached. India has a bimodal presentation of heart failure. Younger population is also suffering. Almost 22% patients are below 30 years, and almost 15% patients are above 50 years. So we have a bimodal presentation where younger population also is suffering from heart failure, particularly due to rheumatic heart disease. So we do not have much data. There is paucity of data as far as heart failure is concerned in India. But nonetheless, Trivandrum Heart Failure Registry has shown that incidence of diabetes in heart failure is about 54%. So we know that heart failure and diabetes, they walk hand in hand, though they actually feed each other. And diabetes leads to heart failure and heart failure leads to diabetes because the pathophysiological basis of both diseases are common, and that is a common breeding ground, and that actually enhances the increased morbidity and mortality which is seen in patients with heart failure. Now, what are the current treatment according to the various guidelines that are there as far as heart failure with reduced ejection fraction is concerned? Suffice to say that heart failure with preserved ejection fraction is now increasingly being recognized by physicians, and we see more and more patients of heart failure with preserved ejection fraction being seen in our OPDs and IPDs. Most of the guidelines and whatever we know about heart failure is for the heart failure with reduced ejection fraction. There is paucity of drugs that can treat heart failure with preserved ejection fraction. There are multiple phenotypes of heart failure with preserved ejection fraction, and most of the drug trials, they have not been able to show sustainable benefit as far as heart failure with preserved ejection fraction is concerned. That has also led for the guideline authorities to not recommend any drug for heart failure with preserved ejection fraction as class 1A recommendation. But nonetheless, heart failure with reduced ejection fraction is uh, is uh, has been scientifically evaluated by various organizations and various authorities for which guidelines have been placed. So, as far as heart failure with reduced ejection fraction, which is also common, we have pharmacological therapies, and they can be categorized into two groups. Therapies which merely control the symptom. These therapies are useful once the patient is admitted in acute heart failure, and therapies which can modify the disease, which can change the course of disease. In the beginning of the lecture, I had said that almost 50% of the people of heart failure, they die within 5 years. So if we can modify the disease course so that they can live longer, and for that, these are the drug therapies which are available to us. So if we look at the symptom control, diuretics are the foremost and most importantly used drugs. And we can verify this, we can substantiate this, that patients of acute heart failure who come to our emergency, then diuretics, IV furosemide is the drug of choice, and they are very commonly used in these patients. Apart from that, digitalis is also a common drug which had been in vogue in late 1900s, but in 2000 AD, it has lost its sheen. Nonetheless, it's an important molecule which can be utilized in patients with rheumatic heart disease where heart rate is a problem, and it can also relieve some of the symptoms. Lately, digitalis in current studies have again come back with the notion that it is able to control heart rate better, in fact, better than beta blockers. But so far, the guidelines have not adopted digitalis as a frontline molecule for heart failure management. Vasodilators, of course, vasodilators are important, and they form the core of treatment when a patient is admitted for acute heart failure. The disease modifying drugs, the five alive that we'll be discussing later, are beta blockers, ACE inhibitors, ARBs, RBs, and aldosterone antagonist and SGLT2 inhibitors. So these are the various drugs which we'll be discussing in the latter part of our talk, and we'll be talking about how they can help us. As I said, symptom control strategies are actually helpful in the acute stage to decongest the patient, and disease modifying strategies, they improve hemodynamics and provide neurohormonal control so that the course of the disease can be changed and hospitalization can be improved. So, what are the drugs that are available? As I said, ACE inhibitors are the drugs that are most commonly recommended, and most of the guideline authorities have given them class of recommendation and level of evidence as 1A, whether it is ESC or ACC, and it is able to reduce the risk of heart failure hospitalization and death. They work on the neurohormonal axis, and ACE inhibitors are the cornerstone after the SALT study that came in 1980s, and they are the cornerstone of heart failure therapy world over. Beta blockers, again, they have been shown to reduce the maximum mortality in heart failure, and they are again modifying the neurohormonal axis by being sympatholytic. And again, they have been given as a class of recommendation and level of evidence as 1A. Mineralocorticoid receptor antagonist or aldosterone antagonist, they also reduce heart failure hospitalization and death. And again, they have been given 1A recommendation by guideline authorities. Now, this is based on randomized controlled trial that these guidelines they come up. For aldosterone antagonists, we know that RALS trial and emphasis trial were there, which established the role of aldosterone antagonist in heart failure. For beta blockers and ACE inhibitor, as I said, there are plethora of trials which establish that these molecules are helpful as far as heart failure management is concerned. Now, diuretics, as we see that diuretics are very low as far as the class of recommendation is concerned. Only ESC recommended, and that too at a lower level of 2AB. So they are very useful. As I said, it is out of context to discuss that a patient of acute heart failure with congestion comes into the emergency and we do not give IV diuretic to such a patient. So that is not appropriate at all. So they are able to decongest our patients and they reduce the risk of hospitalization stay once the patient has been admitted with us. Now, another drug, ivabradine or Fermi channel inhibitor, they are also utilized in heart failure with reduced ejection fraction when the maximum dose of beta blockers have been used or beta blockers are not being used due to some contraindication and other drug therapies are already in place to reduce the heart rate once the heart rate is more than 70 beats per minute. So as we see that chronotropy is an important denominator for heart failure morbidity and mortality. And unless we do not control the rate, these patients are at a high risk. And ivabradine has been shown to reduce the mortality as well as morbidity. However, the class of recommendation is 2, both by ESC and ACC, because this is based on a single trial. Ornis have been, as I said, in last 5 or 6 years, we had important information coming about for heart failure management. And Ornis are one group of drugs, sacubitril/valsartan group of drugs, which have established after the paradigm heart failure trial and other trials which have come up. And they are the mainstay of heart failure treatment. Initially, it was recommended that there should be a replacement to ACE or ARB. However, our current paper on 11th of January 2021, ACC, American College of Cardiology Guidelines on Heart Failure Management Expert Consensus Statement has verified that they can be started not as a replacement, but as an initial therapy for patients who are wet and who need to be given heart failure treatment in the hospital. ARBs, again, they can be given to patients who are intolerant to ACE inhibitors, who develop cough or angioedema, and they can be given along with the other medications. Hydrogen and isosorbate dinitrate combination is a very important combination, very underutilized, though it has been mentioned that it can be given to Black patients. But in clinical practice, it is cheaper than other drug therapies that are available. It has been there for a very long time now. And patients, particularly who are not able to afford due to the uh, chronic kidney disease that is associated with heart failure, or patients who cannot afford expensive medication, this drug is a boon to them. And hydralazine 37.5 and isosorbate dinitrate 20 milligram in BD doses is able to help many such patients, and we have seen in clinical practice that they are very helpful as far as these subgroup of patients are concerned. Digoxin, as I said, they are helpful in chronotropy maintenance, and they can be added on to beta blocker and other drug therapies that we have just discussed. So, heart failure, as we said, is associated with multiple comorbidities. One of the comorbidities is atrial fibrillation, and these patients who have atrial fibrillation, they are compounded with the enhanced morbidity uh, because of the presence of this disabling arrhythmia. Heart failure is more common in the elderly population, and AF, which whose incidence is 1% at 50 years, is almost 10% at 70 years so of age. So it's very common to have heart failure with atrial fibrillation, uh, both together in patients who come for disabling symptoms. So once we diagnose that patient is suffering from atrial fibrillation, it's important to control rhythm first, if that is possible, and if that is not possible, then rate should always be controlled so that we are able to give heart adequate rest so that it does not get fatigued down. So, if a patient of AF it comes in the emergency room, it's important to cardiovert it if possible, and anticoagulation at that time is extremely important. We must give some kind of anticoagulation, preferably parenteral, so that at the time of cardioversion, at least there is no cardioembolic stroke. And it's important, as I said, in acute stage at least, that they should be converted to sinus rhythm, because that will help them in not only uh, getting the atrial kick, uh, that is atrial systole in their cardiac cycle, but also that will help them in improving their longevity as well as reducing their morbidity. If possible, they need to be given drugs to control the rate, beta blockers and amiodarone, and these are the drugs that are helpful in controlling the rate. And anticoagulation is a must, and anticoagulation in the form of novel oral anticoagulants or non-vitamin K antagonists, they should be given so that there is least possibility of cardioembolic stroke. Now, another important aspect is blood pressure control, and it is part of holistic management of patients with heart failure. So, as I said, that heart failure is compounded by multiple comorbidities, and blood pressure should be targeted so that whether it is heart failure with reduced ejection fraction or whether it is heart failure with preserved ejection fraction, we need to control the blood pressure to the recommended levels. ACE inhibitors, ARBs, and MRA antagonists can be used in patients with heart failure with preserved ejection fraction. It has been seen that MRA are helpful, though the TopCat trial was negative, but still MRA are increasingly being used in heart failure with preserved ejection fraction. As far as heart failure with reduced ejection fraction is concerned, we know that ACE inhibitors, calcium channel blockers, thiazide-like diuretics, they are important drugs that can control the blood pressure to the desired reach. Non-dihydropyridine calcium channel blockers and alpha agonists such as moxinidine They should be avoided in patients with heart failure with reduced ejection fraction because it is seen that they contribute to enhanced mortality and morbidity. Non-dihydropyridine calcium channel blockers are helpful in heart failure with preserved ejection fraction, and they can be utilized in such a scenario. Nitrates should be avoided in patients with heart failure with preserved ejection fraction. And as far as possible, we should try to control the blood pressure with the ACE inhibitors, ARBs, or MRAs as far as heart failure with preserved ejection fraction is concerned. Another important aspect is anemia, and it is often neglected, but it has been seen that serum ferritin levels are less than 100 microgram per liter, and though hemoglobin could be almost normal in such patients, and that becomes the basis of diagnosis of anemia in such patients. Anemia, if properly treated, can increase the exercise capacity, can relieve the symptom, and probably can enhance the longevity of life that is that can be attained in heart failure patients who are suffering from anemia. Now, various drugs have been utilized. Erythropoietin stimulating agents were used in the hope that they will increase the hemoglobin. They did increase the hemoglobin levels, but there were also increased thromboembolic events in such cases, and they are not now recommended as a mainstay of therapy. There are other newer therapies which are coming up, which may increase the hemoglobin levels, but they need further clinical trials before they become established for utilization in everyday practice. What we have is iron carboxy maltose, IV iron replacement. They can help in not only increasing hemoglobin levels, but also increasing exercise capacity and relieving symptoms. And they have been endorsed by authorities, the people who make guidelines, as they not only increase the quality of life, but also improve functional status of the patients. Another important aspect is chronic kidney disease. It is imperative that many patients are suffering from chronic kidney disease and they develop heart failure, compounding the problem because many drugs that are given in heart failure, we are not able to give them in chronic kidney disease. And many a times, diabetes is the cause of chronic kidney disease, and that also leads to treatment paralysis as far as the doctor is concerned. Now, we know that heart failure drugs, they have evidence for improving survival with strong evidence for ARNIs, ACE, ARBs, ICDs, and CRT devices that we use, even ivabradine. But in patients who are suffering from chronic kidney disease, the evidence is less strong, mainly because if a patient is suffering from stage 2 or 3 or further chronic kidney disease, they have not been included in clinical trials. There is paucity of data as far as CKD patients are concerned in the involvement of clinical trials. And it is also seen that due to the potassium levels, due to the creatinine levels, they are not able to take medication at the desired dosage. Sometimes not at all. We can give these drugs to these patients. So another important aspect is most of the heart failure drugs, they are excreted to kidney, and once kidney is diseased, that leads to enhanced levels of these drugs in renal dysfunction. And high doses of diuretics, they sometimes lead to worsening of renal function, and they need to be avoided, and they also become less effective once a patient has a very low eGFR. As there is no kidney tissue, diuretics are not able to act on them, and they should be, replaced by some other form of therapy for a volume overload condition that these patients have. Alpha blockers may also cause hypotension and sodium and water retention, and they are not safe in patients of CKD and heart failure with reduced ejection fraction, and they need to be avoided as well. Now, a word about diabetes. Another important comorbidity is diabetes. Patients are suffering, as I said in the beginning of my talk, that diabetes leads to heart failure and heart failure leads to diabetes. So there is a complex interplay of myocardial, cellular, and systemic factors that lead to more patients of one disease becoming victim to having the other disease as well, and their health consequently suffers because of that. So what are the drugs that can be given in heart failure situation if a patient is concerned, if a patient of diabetes is concerned? Then there are not many drugs that can be given except metformin. Many patients believe that metformin cannot be given in heart failure, though there is no large trial on this. But it has been found that metformin is the treatment of choice, can be given unless there is severe derangement of EGFR. Metformin can be given in patients of heart failure with diabetes. How, as I said, it is contraindicated if there is hepatic impairment or severe renal impairment. Otherwise, it is quite safe. Other drugs, especially TZDs, they are very good drugs. They enhance the insulin sensitivity, but they are contraindicated as far as heart failure is concerned. Sulfonylureas, no large trial. They are very cheap, easily available, extensively being used in India, but probably they may increase the risk of heart failure worsening and should not be used. DPP-4 inhibitors, they help in insulin release by becoming incretin mimetics, but again, there are mixed reports, and some of them, they actually worsen the heart failure situation. GLP-1 analogs, they are very good, and especially liraglutide has been found to be useful in LEADER trial, but that's the one molecule which can be used, and sotaglutide is oral GLP-1 analog that can be utilized, not yet available in India, but that has been shown to improve morbidity and mortality in patients of heart failure. Insulin, again, it may cause fluid retention and may worsen the heart failure situation, so cannot be used. So there are two drugs, GLP-1 receptor analog and SGL2 inhibitors, which have been found to be extremely useful in heart failure situation, and they reduce the morbidity and mortality associated, as well as major adverse cardiac events with heart failure situation. So what are the current treatment guidelines that have become vogue, especially after SGLT2 inhibitors, they come into practice? So it all started with EMPEROR outcome trial, where empagliflozin was considered in patients of diabetes for actually non-inferiority. So the investigators were amazed to see that it attained the 3-point MACE. It reduced the CV mortality, it reduced the myocardial infarction as well as stroke. And that was primarily because it was able to reduce the heart failure hospitalization. It was able to reduce the menace of heart failure in patients of diabetes. That led the investigators to consider this as an evidence, and it was substantiated by other trials such as CANVAS program, declared TIMI58, where dapagliflozin was used. It was the largest trial of diabetes, CVOT trial, 17,000 patients evaluated, and it also showed that the 3-point MACE were reduced with dapagliflozin, primarily due to reduction in heart failure hospitalization. Credence was a trial where it was a renal trial, canagliflozin, and it also helped opinion that they are safe in heart failure hospitalization. So, premises was basis of these trials that SGLT2 inhibitors are actually heart failure drugs which can also be used in diabetes. They are not anti-diabetic agents which can be used in heart failure, but it's the other way around. They are actually heart failure agents which have very low risk of hypoglycemia and can be utilized in patients of diabetes. So if you look at the meta-analysis of SGLT2 inhibitor trials in heart failure, the primary composite outcome of DAPA heart failure and EMPEROR-Reduced, both these trials came recently, and it was shown that SGLT2 inhibitor was better than placebo as far as the primary composite endpoints of heart failure hospitalization and CV death is concerned. So, identical 25% risk reduction was seen by both the molecules, empagliflozin and dapagliflozin. And the p-value, look at the p-value, it is 0.0001. And test for heterogeneity was 0.89, meaning thereby that both the trials can be compared to each other. And it was also seen that first hospitalization for heart failure was also substantially reduced by both the molecules. So both these trials were fairly large trials, almost 1,800 patients in each arm in EMPEROR, and almost 2,300 patients in DAPA-HF in each arm, and almost half of the patients were not suffering from diabetes. So it led the investigator to believe that that SGLT2 inhibitors are not only reducing the hard endpoints, but it is irrespective of the fact that patients are suffering from diabetes or not, and they are able to reduce the hard endpoints in non-diabetic patients also. Look at the all-cause mortality. Again, both the trials had similar results. EMPEROR-Reduced, though, had a very high-risk population. Still, it was dapagliflozin which was able to reduce all-cause mortality to a little more than the EMPEROR-Reduced trial. We cannot compare head-on both the molecules, but if you look at test for heterogeneity effect, then statistically it can be, and it established that both SGLT2 inhibitors, probably dapagliflozin, a little better than empagliflozin, and it not only reduced CV death to a greater extent and all-cause mortality to a greater extent than empagliflozin, but nonetheless, it appears to be a class effect, and both these drugs can be safely used in patients of heart failure, irrespective of the fact that they are suffering from diabetes or not. So, what do the future holds for us in 2021? What do the future holds for us? And if you look at this slide, this is 2016 recommendation where symptomatic patients with heart failure with reduced ejection fraction and ACE, ARB, and beta blocker are the first line drugs. You may add MRA if the patient is still symptomatic, and you may go on with adding ARNIs, or you may go for CRT if there is a broad QRS LBP, or you may also add ivabradine if the heart rate is more than 70. So these are what has been told to us since long, and this had been a guiding light for physicians all over the world to treat their patients of heart failure. But of course, there is limitation to what has been said and what has been taught, by these guidelines. First of all, it's the conventional sequence for initiating heart failure therapy, and that has been done on the basis of how these drugs came into being. ACE inhibitors, as I said, came in 1980s on the basis of consensus and SALT trial. So they are always given first come, first served basis criteria. But nonetheless, it has been seen that there are other drugs which are even better than them, and they have not been given a place. So this is the criticism of what was being, told to us for treating our patients of heart failure. Another important is that fact is that it's important to start treatment at the early. Please don't wait for your best drug to start late, because whatever benefits they start appearing within the very first month of treatment initiation. And if we wait for ARNIs or dapagliflozin to be started after 30 days, probably these benefits will not be apparent to our patients of heart failure. So we should go for the drugs which are well tolerated, which are more effective, and which have been shown to reduce the heart failure morbidity and mortality in randomized controlled trial. That is their evidence base. So there is a need to change the fundamentals of foundation therapy, and we need to go for drugs with the aim of achieving the targeted dosage. Uh, Important is that SGLT2 inhibitors can be given in a single daily dose, and they have, like dapagliflozin, can be given in a 10 milligram single daily dose. So unlike ARNIs, where you need to start and then build up the dose, and 6 months you have to reach the target of 200 milligram BD, here you have a molecule which is kind of fill it, shut it, and forget it, where you start off with 10 milligram with breakfast, and that's all that you have to do for the rest of the time that patient needs this drug. So the experts now have proposed that this should be the correct approach. It should not be the senior drug gets the most high rank of initiation, such as ACE inhibitors. But the best drugs should be given to our patients, and SGLT2 inhibitors and beta blockers. As I said, beta blockers have reduced the maximum mortality in heart failure patients compared to other drugs. And they need to be given and early in the course of disease. As I said, in the first 30 days, we need to give the best drug so that our patients are able to attain the maximum benefits. Then, if the patients are still symptomatic, you may go on to add other drugs such as ARNIs, and you need to start slow and then build up the dosage of these drugs to the guideline-directed medical therapy. And the third step, after a week or so, you may add aldosterone antagonists, and within the very first month, you have started your patient on the best of the drugs that are available. And these are the drugs that have not been only shown to be efficacious, but they are also safe in heart failure patients. Now, what will be the implications? Suppose we start giving these drugs to all our heart failure patients, then this is a very important paper that has come up recently, where they have tried to compare the event-free survival and treatment differences with the comprehensive guideline-directed medical therapy versus conventional therapy. And it is seen that if we are able to give our patients ACE, ARBs, mineralocortical receptor antagonists, SGLT2 inhibitors to the correct dosage that has been mentioned, and the patient is of aged 55 years, then we may add 8.3 event-free survival to such patients. So heart failure patients are not only concerned with longevity, they are also concerned with quality of life. It has been seen that giving dapagliflozin to our patients of heart failure you can increase the Kansas City cardiomyopathy questionnaire score by almost 5 points. That is almost equal to giving him a biventricular pacemaker, CRT device. So that is the power of these newer molecules, and it is extremely important that we give these best drug therapy early in the course of disease so that our patients are able to live longer. Suppose we give all the drugs at the optimal doses that has been suggested. Again, a very important paper which was published in JAMA Cardiology as early as 2020 last year. And it says that if we are able to give the drugs such as ARNIs, beta blockers, aldosterone antagonists, and SGLT2 inhibitors, we are able to reduce all-cause mortality by 73% and absolute reduction in all-cause mortality by 26%. So that is a mammoth difference that we can make by giving the guideline-directed drug therapy to our patients. So early in the course of my talk, I discussed 5 alive. These are the drugs which can make our patient alive for a long time. It can prevent them from getting admitted to the hospital. If they get admitted, they can hope to go back home early, and less of readmission rate, less of morbidity, and less of mortality, with increasingly a life which is full of quality. They'll be able to have a better quality of life. They'll be able to go for grocery shopping despite having terminal heart failure. And they can also go for destination therapies which are coming up. In this talk, we have not discussed about the non-pharmacological treatment of heart failure. There are plethora of newer innovations that are coming up as far as that aspect is concerned. But these drugs can make these patients suitable for these destination therapies and other non-pharmacological therapies that are now becoming vogue in heart failure management. Suffice to say that ACRBs or neprilysin inhibitors, beta blockers, aldosterone antagonists, SGLT2 inhibitors, they can together in coming years make us believe that none of our heart failure patients who can afford this medication or other therapies, surgical therapies or percutaneous therapy would be dying due to heart failure illness at least. And that will be a big boon to medical knowledge, that will be a big boon to scientific research. And I truly believe that such a scenario is possible in coming years. So that is all, friends. I hope that you found this talk useful. And if you have any questions, I'll be very happy to answer them. Thank you.
Thank you so much for such an insightful talk, sir. Moving on to the questions, we have our first question from Dr. Radheshyam Gupta, who wants to know the cause and treatment for thrombocytopenia and anemia in heart failures.
Which treatment are you asking about?
Thrombocytopenia and anemia. So the cause and treatment for this in heart failures.
Well, in heart failure, thrombocytopenia is a different aspect, but anemia is very common in heart failure situation. Primarily because, as I said, that only 3% of the heart failure patients are not having any comorbidity. So there are patients who are suffering from diabetes, there are patients who are suffering because of CKD, and there are patients who have other illnesses such as dyslipidemia or sleep apnea or hyperuricemia or obesity. So these are the patients who have multiple comorbidities. There is also nutritional deficiency. Most of the heart failure patients have vasculopathy as well as gastropathy in their GI tracts, and they have anorexia or they don't like to eat food. Many a times drugs such as digoxin are going on, which also cause anorexia. Many a times they are also on oral anticoagulants or drugs like antiplatelet agents, which may also cause bleeding from the GI tract or cold bleeding. And there are dietary restrictions to vitamin K antagonists such as warfarin and other drugs that are there. So these are the other factors which can lead to anemia. If patient is suffering from CKD, then erythropoietin is also not properly, built, and that also causes reduction in hemoglobin levels. Diabetes per se, patients are nutritionally deficient, and they also get anemia.
Okay. So the next question that we have is, are the new modern therapies costlier than before? Could you highlight on the cost structure?
Yes, they are definitely very costly. If you look at enalapril and if you look at the modern drug treatments such as SGLT2 inhibitors or ARNIs, they are extremely costly. And these drug treatments are also patented, so meaning thereby that they cannot be made cheaper and they cannot be, made by other companies without the consent of the parent company. So these are definitely very expensive molecules, but there is a trial of Hermes which happened and which said that the quality of life and the amount of life that is spent, that is gained by taking Hermes is much more valuable than the cost that you actually spend on that. So people who can afford this treatment, obviously it is a boon to them. But of course, for a country like ours, where people are, grossly restricted as far as cost is concerned, probably these molecules are not available for the masses.
So on similar lines, there's another question about the time frame. Do you think the newer therapies take less or more time than the old traditional procedures?
I think new therapies are quicker. If you look at the Kaplan-Meier curves of DAPA heart failure trial or paradigm heart failure trial, both the curves they started separating early within the very first 4 weeks, and they kept on separating. That in plain words is that both these molecules are effective very early in the disease onset, and as long as the patient is taking them, compliance is there. They keep on reducing the morbidity and mortality due to heart failure.
Okay. So that was all the questions. Thank you, Dr. Kocha. It is always wonderful to listen to you. We are grateful that you're always for your contribution to Dr. X's webinars and that greatly benefit our doctor community at large. I would also like to thank our viewers here whose interaction and interest make these webinars so successful each time. Thank you so much.
Thank you. Thank you.
Yeah. Sorry. So please.
I hope all of you enjoyed this seminar as much as I did. And I thank you for your patient listening. And we hope that we meet on this platform more often and discuss more important and equally interesting topics in future. Thank you.
Thank you, sir.